And joining us now on the debate in Pittsburgh, Pennsylvania, Deborah Davis. She's founder of the Environmental Health Trust and the author of The Secret History of the War on Cancer. And back here in studio, Robert Buckman, medical oncologist with Princess Margaret Hospital. Alison Symington, Vice President of Outreach with the Ontario Genomics Institute. And joining us once again, Siddhartha Mukherjee, author of The Emperor of All Maladies, a biography of cancer. I want to thank you two for joining us here in the studio. Deborah Davis, it's great to have you on the program once again from Pennsylvania. And let's start with you, Deborah Davis. Richard Nixon's War on Cancer launched 40 years ago this year. So far, in your view, success or failure?
It's been a success in some small areas, but it's been a failure because it has not addressed the known causes of cancer that were known when the president launched the war 40 years ago. For example, tobacco, asbestos, vinyl chloride, synthetic hormones were known 40 years ago to cause cancer. And yet the war focused solely on finding and treating the disease. And in that regard, we've had some spectacular successes. We have dramatically improved our ability to find and treat breast, colon cancer, for example. But we have not done a good enough job on the environment. And we know that because of the toll that we're seeing from lung cancer-related deaths even now.
Alison Symington, success or failure 40 years later?
Oh, I think it's a success. Except if you believe the word we were going to beat cancer. So I think it's the hope versus the hype. It's the same problem you have with the Human Genome Project. We promised too much. What we found the success has been that it's not cancer a disease, it's a myriad of diseases. What we're starting to understand, we know some of what those environmental things were, that's absolutely true. How do they influence the genetic makeup? We're still sorting all of that out. And so while we can say for sure some of those things cause cancer and need to be dealt with, how you can separate out different cancers for different patients, that war, that started all of that research or continued a lot of that research. So I'm not one to throw the baby out with the bathwater to say we didn't win on one disease, because it's not one disease. But we need to do big science if we need to understand these diseases.
Rob Buckman.
I agree with all of the above. Quite seriously, this is the big point. There is not a single disease called cancer. Just the same, there isn't a single disease called infection. I mean, if you get a cold, it's an infection. If you get Ebola virus, it's an infection. But there isn't one single disease called infections. And actually lumping them all together as cancer is actually bad. So I would say the 1971 war on cancer was a real problematic thing to declare war on. It's like declaring war on death. Success or failure? Well, it's a real problem because it united all of the cancers, which are just as Alison said, are at least 300 different diseases, depending on how you slice up even cancer of the breast, for example.
Okay, that having been said, you want to say more successful or less successful 40 years later? Let's put it that way.
Well, I think the successes are slowly coming. I agree with all of the above, as I said, as Robert was saying. It's absolutely true that there were known carcinogens. There are absolutely known carcinogens that we haven't done enough about. Tobacco being a big major one of them. We also haven't achieved the kind of promise that was promised up front. One note that I personally want to make is that it's absolutely true that there's not one illness, there's not one disease. It has many myriad forms. But I also want to sound a cautionary note against over-dramatizing the diversity, because there are connections. Cancer, there are deep connections. And if you forget what those connections are, you fall into a kind of hole, particularly around advocacy. So there's becoming a kind of theory now that, since breast cancer and prostate cancer are so fundamentally different diseases, we should put different pots of money into breast cancer research and prostate cancer research. And every $1 that goes away from lung cancer goes into, leukemia. That's not true. In fact, many of the seminal advances in treatment, prevention, and cure of various cancers have come from completely heterologous cancers. Leukemia becomes a very close relative to a variant of gastrointestinal cancer. So I think, if we overemphasize the diversity, you also begin to kind of create a nihilism around the fact that there's important connections, and we learn through those connections.
Deborah Davis, do you agree with that, about those connections?
Absolutely. And I also want to say, though, your first question, Steve, there was the credible political environment out of which this war on cancer emerged. Think about it. The United States was in the midst of losing a huge war in Southeast Asia. The president mounted two wars at the same time. One was the war on cancer. The other was the war on drugs. The metaphor of war one can quarrel with applying it in that situation, because in both those cases, whether it's drugs and cancer, we're dealing with a very complex phenomenon, and I think that it was very misleading, although perhaps politically popular. There was a section that didn't make it into my book about how Edward Kennedy and Richard Nixon were fighting over which one of them hated cancer the more, right? Because they both wanted to show how much they hated cancer, and this was going to unite people. And of course we all hate cancer, but that's besides the point. Mounting a war on this disease, I think, led to a number of misconceptions about it. And yet, while we've made progress, what do you call it a war after 40 years?
Well, let me pick up on this angle.
You get pretty tired after 40 years.
I hear you. Let me pick up on this angle then. Part of the war is just bucketfuls of money towards research. Do we spend too much of our potential healthcare research dollars on cancer research?
Well, that's a tough question, isn't it?
Well, that's what we do here, Alison.
It's a very tough question. And so, and especially in Ontario, because Ontario spends huge buckets of money on research in this field, as does actually Canada, both with the Ontario Institute of Cancer Research, PMH we were talking about before.
Princess Margaret Hospital.
Princess Margaret Hospital. So do we spend too much? Well, okay, so I'm in a difficult thing. I would say no. I don't like the question because if I had more money to spend everywhere, I'd spend it everywhere.
Yeah, but we don't.
It's very, very intelligent direction. That's the important thing.
Yes.
You know, the one thing that really is a clear waste of money is me tooing. You know, it's simply doing the same thing. And
what does that mean exactly?
Me tooing, just following the same thing. Somebody, I mean, a few years ago, somebody said, oh, they've done a test with this particular cancer drug, cisplatin, at 50 milligrams per meter squared. They know that 200 milligrams per meter squared is excessive. Here's a study where they said 75. They haven't done 65. Let's do 65. And I said, no, that's really that would be a waste of money. Merely sort of mindlessly me tooing, hoping that you're going to get the answer like Mop did for Hodgkin's disease, unfortunately is not an intelligent way. It may be that we need more direction of the money, not simply more money.
I think we're not spending enough money. I mean, just to give you a couple of examples, just to put the money in perspective, the National Cancer Institute budget of the United States is about $5 billion a year. The United States spent anywhere between $1 to $3 trillion on the recent war in the Gulf. That is anywhere between 1/200 or 200 times to 600 times the budget of the National Cancer Institute for a year, right? The number of deaths from cancer in the United States this year is going to be 600,000 odd deaths. The number of young deaths, anywhere between under the age of 60, is going to number in hundreds of thousands. So the scope of the problem, there's a disproportionality of the money being spent. But I agree completely that the money has to be, every money has to be spent strategically.
So to answer back to that question, because my wasn't very good, in comparison for that, absolutely agree. It's an overall underspending on science in general that is a huge problem. So if you ask me, do we spend enough on environmental science versus cancer science, I can't answer that question because you need to spend more on all of it.
I bet Deborah could answer that question. Environmental science, go ahead.
Well, no, what I'd like to say is that Sid is absolutely correct. We do not have a large civil conversation about the priorities and the way we're spending money on things, whether it's war, investing in infrastructure, or my own favorite right now, we have lost a whole generation in science and training and engineering.
Absolutely.
People are not going into science and engineering now because there are no jobs and there's no training programs. And we are going to pay the consequences of that and lose our ability to compete in the world because of that tremendous failure to fund the basic training in science and engineering. It's a tremendous problem for all of us. Having said that, I think that we would probably all agree that we need to target what the money goes for in cancer. And just as Dr. Buckman said, this Me Tooism, which there's been a ton of, is really, the only way that's going to be addressed is through creating groups of wise people who will come up with advice. And right now, as you know, it's sort of the drug of the week or the fad of the week. Scientists are social. You know, we don't like to admit it, but we are social. We follow fads and fashions. And that's part of the dilemma that we face here as well.
Let me pick up on something that you and I talked about, Sid, in our conversation earlier, and I'll go to Rob on this one. There was not that long ago, a time when you couldn't say breast cancer in the New York Times.
Yes, I heard that, yes.
The language of talking about cancer has changed. We are no longer dying from cancer, we are living with cancer.
Absolutely
Is that an
right.
important distinction to make?
Well, yes, it is. In Canada, literally, it's somewhere between 50 and 55% of people who are diagnosed with a new cancer this year will not die of that cancer. And it's a very important point, as somebody once said, that they'll die at their appointed time of nothing serious, which I like that. I like that view. Very, very important point. If it had said 45% of cancers, they will not affect you and they will not shorten your life. That's a very, very important thing indeed. I think we are actually at the stage of thinking about the cancers as some of them as chronic diseases. Chronic diseases like blood pressure. I mean, I've said this many, many times, but if a woman goes to a hospital and says, I had chest pain, and they find a breast lump, I mean, she might say, oh, well, I was sure I had a heart disease, but that breast lump, thank goodness, wasn't cancer. Actually, it's completely the wrong way around. If that breast lump was cancer and it was a small, under 2 centimeters, lymph node negative, it's the end of the story. She's never going to bother her at all. The heart disease is going to be a serious problem. One day, a woman will say, oh, sure, I just had a little touch of breast cancer there, but thank goodness the chest pain was reflux, not heart disease. And that's what we're aiming for. I'm sorry, Sid, when you write your next book, could you call it The Emperors of Some of the Maladies? The biographies of a few of the cancers.
Let me just...
I'm sorry.
Remaining cancer.
Let's clarify this, because I mentioned to you that one of the people who wrote book reviews sometimes were not happy with your use of the singular biography.
Yeah.
He was one of them.
I was guilty as charged. I'm sorry.
Yeah.
The book is fabulous, and it'll change. It will change the minds and the attitudes of everybody who reads it. But I wrote a book. This is not advert, but the title was "Cancer is a Word, Not a Sentence." And the point is, cancer is a word, and you can't have a biography of a word, and it just doesn't matter. It doesn't matter. It's a great book. Thank you so much.
It won the Pulitzer, Rob.
It did.
Okay.
I can stand up.
Moving right along.
Yeah,
moving right along. Sid, I'll get you to comment on this part here. I want to read a little excerpt, actually not from your book, but from a piece in the New Yorker from last year. Research, of course, increasingly allowing us to understand risks for various cancers. You get screened for genetic markers. For specific cancers, you can make decisions based on your knowledge of that. Here's what they said in New Yorker about that. A world in which cancer is normalized as a manageable chronic condition would be a wonderful thing. But a risk factor world in which we all think of ourselves as precancerous would not. It might decrease the incidence of some forms of malignancy while hugely increasing the numbers of healthy people under medical treatment. It would be a strange victory in which the price to be paid for checking the spread of cancer through the body is its uncontrolled spread through the culture. Agree?
I don't agree, because I think it's somewhat of a false dichotomy. Because I think one of the tasks that's facing us in cancer biology now is to precisely discriminate the kind of cancer that will kill you from the kind of cancer that won't kill you. So in other words, the PSA test is a thing of the past. We shouldn't be really relying on...
for prostate cancer.
For prostate cancer, right? Which, now the problem with the PSA test, as you know very well, is it picks up a whole bunch of people, and some of them will have the malignant, nasty variety of prostate cancer, and some of them will have not the malignant, not the nasty variety of prostate cancer, but both will be lumped as men who have prostate cancer. Now that's obviously a false lumping, because the two behaviors are completely different.
But what do you say, don't get checked?
No, I would say invent a more sophisticated test.
And he's right. A lot of prostatologists would actually say don't have a PSA for exactly that reason, that it would identify a cancer, but it cannot identify the kind of cancer that might kill you from the kind of cancer that will not. So it's a very, very important point.
Deborah, you want to weigh in on that as well?
With breast cancer, yes, with breast cancer as well as with prostate-specific antigen, the PSA, we've got to become more sophisticated at what we're looking for. There may be markers of hormone metabolites ratios. For example, for breast cancer, there's never been adequate study of the importance or not of the ratio of 16-alpha to 2-hydroxyestrone. These are two types of estrogen metabolites, which show some promise in postmenopausal women being useful for predicting breast cancer risk and even predicting the value of different
Deborah, I'm going to jump in
therapies.
for 1 second there, because you spoke something that wasn't English a second ago, and we don't like that on this program. Now tell me what you meant by all that.
I'm sorry, let me try it again. For breast cancer, there are ways of looking at blood tests that might be able to predict who's going to get breast cancer and who's not. And the prostate-specific antigen, or PSA test we've just been discussing, had looked like it was going to have a lot of value, and it turns out that it falsely predicts things so that you can have a high PSA and have an infection and not have cancer at all. And you need to know the difference. And really, there's a lot of unnecessary surgery and unnecessary treatment that's going on because we've been relying on this PSA test. So we need better tests. It doesn't mean that we shouldn't do none, but we should stop relying on tests that don't work very well.
Is that a concern here, that we're unnecessarily removing many men's prostates because of this test that is not what it ought to be?
So I'm not a cancer doctor, but I would say probably that's true, because it's certainly true when you talk about the one size drug fits all. So even if it's not cancer and we're just talking about drug therapy, you're talking about cholesterol and statins and things like that, the drugs that lower cholesterol, lots of people don't react to those drugs, but we give them anyway because their cholesterol's high. And so it's the same situation here, and what you really need to do is separate out your group of patients, what we call it stratify. So stratify the patients so we know this group of patients should get the therapy, this group of patients shouldn't get the therapy. Maybe this group of patients should get the therapy, but we understand that their adverse events will be worse and they need to be informed.
Is our knowledge sophisticated enough to be able to make those determinations and distinctions right now?
I would say no, and probably not for most cancers. And we can talk about that. There's some, I mean, the example most people use in terms of choosing a correct therapy is Herceptin. So there's a marker for the particular cancer called HER2, that's Herceptin, works on breast cancer that is what we call HER2 positive, has that marker. So people who are not HER2 positive shouldn't get Herceptin. It's not going to necessarily help. So, so we're getting there. That's kind of the promise of a lot of this stuff coming along, a lot of the research. But you know, I'm careful not to overpromise that we've done it for everything.
We're getting there a little bit, a tiny little bit. Yes. Like there's a KRAS, which is it's called KRAS, is a little piece of DNA.
Mutation.
And in bowel cancer, it tells you when the chemo is not going to work. Right. Now, that's not very sexy. It's not very wonderful to say, yes, we can definitely tell you that treatment is not going to work. But actually, it does help a bit because it saves people from having unnecessary toxicity from treatment. One day, and I think Deborah's absolutely right, one day we will have a predictive test of these particular cancer cells. What is likely to happen in your particular case? Not breast cancer, not prostate cancer, but in your particular case. Should you have therapy or should you not? If it is going to benefit, then maybe it's more justifiable to have a horrible toxicity. And if it isn't, then absolutely not do it. Prediction is, I think, going to be the name of the game.
You all seem to be roughly on the same page of many of the issues related to the topic that we're discussing here tonight. However, I wonder if I can find a bit of space among you when it comes to the following. The preponderance of cases of cancer happen because you're born with it. It's in your genetic makeup. Or the preponderance of cases of cancer happen because of what we're doing to our environment. Deborah, go.
Well, we know from studies of identical twins that start from one egg split in two at birth that identical twins look quite similar genetically in terms of their chromosomal bands at age 3, and by age 50, they don't even look related to one another. That's telling us that basically for most cancers, genes give us the gun, the environment pulls the trigger. The National Cancer Institute has reported that for breast cancer, 1 in 10 or fewer cases occurs in a woman who has inherited a risk from her mother or father. But all cancer comes about when your genes stop doing their job. As Sid says, our healthy genes go out of whack and we end up with cancer as a result. That happens as a result of what happens to you after you're born, not before.
Sid.
I agree. I mean, as I said, that this idea of a gun and the trigger analogy is kind of helpful because you need both. You can imagine situations where, there are certainly familial forms of cancer in which the cancer is passed down from in the family, but they tend to be more rare. They tend to be, there's some common ones. Breast cancer, there's certainly examples of that. So it's a combination. Cancer by its very nature, if you look at the very pathophysiology of cancer, by its very nature, it's a combination of genes and the environment. Both of them are cofactors in the creation of cancer.
So you couldn't say there was a preponderance of one versus the other?
It depends on which cancer we're talking about. So for instance, where you have, in cases, for instance, breast cancer, we now know, I'll give you one good example. We now know in breast cancer, the use of exogenous hormones is a clear cofactor and in some
exogenous
hormones like hormone replacement therapy,
Okay.
like excess estrogen
Contributes to it.
Contributes to it. We know it's very clear. Epidemiological data is quite clear about that. So in that case, now again, it's an artificially created environment, but it's an environment. It's the environment that you put into your own body. In the case of or actually I would say physicians put into women's bodies, and so that's very clear. On the flip side, we don't understand, for instance, why a child will suddenly get acute lymphoblastic leukemia while his identical twin, doesn't get the same kind of leukemia. And it's a child, so the amount of environmental exposure might be there, but it's certainly much less than the kind of exposure you get from, having a pill of estrogen every day.
Rob.
You slipped it in again. You tried to say cancer as if it was one disease. I mean, a very, very important
Shame
point.
on me, I
Your
did it
question is unanswerable in terms of genetics versus environment, because cancer is not a single disease. Cancer is analogy like a traffic
If
jam.
I use the plural, cancers.
Cancers, yes. Okay.
Can you help me then?
Yes. Which cancers are you talking about? No, I mean, some cancers are clearly environmental in the sense that if you smoke, you have a higher chance of getting lung cancers, cancer of floral mouth, cancer in bladder, and so on, so on, so on. And if you don't, you won't. So, I mean, always there's a balance. And even not everybody with a genetic abnormality for breast cancer is going to get breast cancer. So always there is a balance, a seesaw between genetics and exogenous environmental influences. It depends on the cancer, and it depends on the particular population that you're looking at.
So one thing that's important
Let me share something with you that comes from Israel that I don't know what to do with. I've been working with colleagues there on this for about 10 years. We are seeing the following pattern in patients in Hadassah Medical Center in Jerusalem. We're seeing that mothers are being diagnosed after their daughters with BRCA1-related breast cancer. That is a genetic mutation, BRCA1,
yes,
that increases the risk of breast cancer, is showing up in the daughters in their 30s and then showing up late in the mothers in their late 60s. So there's something going on here.
What do you think it
where
is,
the
Deborah?
Mutation, obviously, I believe it's an environmental factor or factors, because it's not going to be one thing in the environment. We know that. Just as there is not one cancer, there's not one environment. It's nutrition, it's lifestyle, it's where you live, where you work, what you eat, what you do, and whether or not nowadays you put the cell phone in your bra. All of those things will have an effect.
Sid, you
but
wanted
we're
to say.
seeing this pattern that's really hard to explain. Why are daughters getting diagnosed and then they go back and find the mutation in the mother?
Okay, Sid,
We don't know.
Well, one thing that's important, and this is one of the reasons that we should be spending more money, particularly on finding these environmental carcinogens, is you have to be specific about the carcinogen. You can't say, well, the water is causing cancer. You can't say the air is causing cancer, because that statement begins to lack sense. You can't not drink the water. You can't not breathe the air. So they have to be removable, identifiable carcinogens, which can be modifiable, behaviorally modifiable, for instance, would be very good. Like tobacco, again, a good example.
But that's one of the questions I have for you, Sid, is that we don't live in a bubble, and because we can't do that kind of research on living people, it's unethical, we would agree. How can we be smarter about using experimental data where we have it? You talk about the development of therapies beautifully in your writing, but where are we now with understanding environmental causes of cancer beside waiting for dead bodies to mount? That is my argument with some of your work.
Let's get him to
frankly.
respond.
Well, there are two responses. Number one is the idea, again, that there's a dichotomy between prevention and treatment and genetics, I think is somewhat, was certainly true in the 1970s and 1980s. That's not true anymore. So in fact, much of what we're learning about how to treat or even understand cancers, for instance, the understanding of BRCA1 ultimately backtracks into understanding, therefore, into how environment causes BRCA1, a breast cancer in a woman who carries that gene. So the dichotomy doesn't exist anymore. In fact, let me give you one more example. Tamoxifen was a medicine that was originally invented to treat metastatic breast cancer in women. Well, guess what? It has a powerful effect in preventing breast cancer in women who have never had breast cancer. So again, here's a medicine that was invented entirely to treat breast cancer, but if you use it appropriately in appropriate kinds of contexts, you can use it to actually prevent breast cancer. So I think these two silos have finally, thankfully, begun to communicate with each other, and I hope this communication continues.
Okay, let me get Allison in on this then. Okay. On genomics, how successful have advances in genomics been in treating cancer?
So I think they're just starting, right? So Herceptin is an example, a perfect example of an advance in genomics that worked, and so they were able to do that. The big studies now, and it's interesting going back to something that was said earlier about you've got to be careful not to talk about it as a too diverse disease. So one of the questions that was just asked was about how do you pass out this information? How do you figure it out? And one of the ways you need to do is these very large cohort studies, which take a huge amount of information, and you're not just taking their genetic information, you're taking everything else as well, because we want to know, perhaps there's a common link, perhaps, with the daughters versus the mothers, and definitely the environment they've grown up in is different than the mothers. And so we want to look at those kind of things. And people really need to understand that genomics is not the study of just the genes, but it's this interaction of genes with other genes, so the environment within the cell, as well as the full environment outside the cell. Okay. So I would say if you look, there's some really big studies going on right now. Just to talk about a couple of Ontario ones, we're involved in the international consortium where they're trying to type 50 different cancers, as many patients as they can involved in that, to try and kind of parse out exactly what's going on here. And another one is the project where they're looking, it's called the 1 millimeter challenge, because one of the things that genomics potentially could help us with is finding cancer before it's big enough that we can see it physically, or those kinds of things. Yeah. And so that's hugely important, because that goes to prevention, that goes to living with it because you catch it early enough.
Let me go to Rob on something that's in his field. Using HIV to kill cancer cells.
Oh, yes. That's called honorable precedent. There have been several different viruses that have actually been used to actually basically target the cancer cell. Those are very important things. Unfortunately, they're not going to be widespread, and it's very, very unlikely that will make a huge difference to the cancers. It may make certain differences to certain cancers in certain circumstances. And for example, I think the earlier studies were in the nasopharyngeal cancers. Yes, but that's not the big picture. That's the small picture.
Small picture. Sid, Gleevec, a drug that you talk about in your book. What is it? What does it do?
Well, Gleevec is really an exemplar more than anything else. And for a long time, the fantasy of cancer therapy was, could you find a medicine that would specifically kill cancer cells while sparing normal cells? And there were few. They were rare, and there were a few. Now, what's interesting is they were typically found serendipitously. They were typically found through a combination. You would go to a plant extract, for instance, and try to find that medicine. Now, Gleevec is an exemplar of a medicine that was synthesized using the biology of the cancer from step up. So in other words, you began with understanding, with decoding that particular cancer cell that happened to affect, Gleevec happens to affect a gene that is only present or primarily present in this leukemia, chronic myelogenous leukemia. And so Gleevec is a kind of medicine that only will kill those leukemia cells and will spare every cell in the body. And this is a remarkable kind of, chemically speaking, it's a remarkable chemical.
How many successful clinical trials have you had of that? I mean,
well, what's nice is, as a professor of mine used to say, you don't need too many good clinical trials for aspirin. When a medicine works, it works. And that's one of the problems in cancer. This goes back to what Bob Buckman was saying. There's this Me Tooism. Gleevec doesn't need Me Tooism. You don't need to have a Me Tooism. You know the dose. When it works because patients come out and you know it from the third patient who was treated.
But I thought I read in your book that it's been tried in 4 different cases and the results were mixed, and therefore you don't know that it works yet all the time.
Gleevec, no. Gleevec, for chronic myelogenous leukemia, it has now become standard of care. It is now indisputably true that although even up to 10 years ago we were comparing Gleevec with other forms of therapy like transplantation. Not true anymore. Patients with chronic myelogenous leukemia are now uniformly, except for one exception here or there, given Gleevec.
Okay. Deverett, do you see a future where we're going to shift focus from the massive effort behind finding causes, especially environmental, to eradicating the causes? I wonder if we're going to get to a society where we're actually more concerned about cleaning up the pollution in the air and therefore stopping the cancer before the cancers, before they have a chance to happen.
Well, actually, in an interesting way, China may be setting the stage for some of this, because the Chinese are dealing with massive epidemics of cancerous valleys and rivers where they have incredibly high rates of cancer, and they know very well it's because of their profligate use of industrial chemicals where they have levels of exposure to benzene and many things banned in the United States and Canada that have been used in China, and they're seeing a horrible impact because of it. The Chinese government has actually taken steps to clean things up because it's that bad. And I think it's going to set the stage for rethinking a lot of the way that we deal with the environment generally. Now, having said that, having survived losing both of my parents to cancer, I fully understand and want and support the need for research to improve treatment and finding of cancer. We have to do that. Right. But think of it like this. If you had a cliff with people driving off of it routinely, wouldn't it make sense to put a barrier on that cliff rather than to improve your ability to rescue them with an ambulance every time they fell off? That's kind of where we are right now. We've gotten much better at rescuing people who fall over the cliff in certain types of cancer, not all, certainly not in brain cancer. But we would be much better off if we could stop people from falling off altogether by preventing them from getting to that stage. And that's why I'm focusing some of my attention now on what the World Health Organization has declared is a possible cause of cancer in humans, cell phone radiation. Because we don't know for sure what it's doing to people yet, but we have very good, compelling evidence that it is increasing your risk of a whole bunch of things. And I think we have to pay more attention to the environment. And if you look at funding at Health Canada now, for Environment Canada, for the United States EPA, which is under attack for existing by some political parties right now, we are at an all-time low of monitoring for the environment, providing worker protection, and providing environmental regulation protection. My gosh, they're talking about doing away with the Clean Water Act. I mean, think about what that would mean in the United States and Canada if we had no controls on such things.
We've got people here who want to get in on that as well. Alison, then Rob.
I have to say, actually, I totally agree. And in fact, I was at a high school today, and I did a couple of high schools last week, and the title of the talk is Human Health is Not All About Humans. And so the title is, and it's about genomics, and it's about the genomics work being done in cleaning up the environment, in providing food, all of those kinds of things, increasing nutritional value. And so absolutely we need to look at those two things. And none of these things, cancer or cancers, or many of the other diseases, live in a vacuum. We don't live in a vacuum. I would be worried about over-promising how well we're going to do with some of those environmental influences. We've had not a great success in society, with the exception perhaps of smoking, although still not completely, of really advancing and changing people's lifestyles. We talk about healthy eating, we talk about nutrition. We still, certainly at the moment, currently fall off the bandwagon all the time.
Rob.
All I want to argue with Deborah, just a slight caveat, it's not a barrier in front of the cliff. It's many barriers, it's many roads to the edge of the cliff. I'm making this point quite seriously. I mean, some people drive off the cliff because they want to. It's suicide. Maybe the best way of stopping a suicide is not actually a barrier, but actually counselling or whatever. You know, I'm just making the point that even though that we see the end product, which is cancer, there are many, many different diseases. There are many roads to that particular edge of that cliff. And I just want to make the point that we're not being negligent in not paying attention to the barrier. We're just looking.
Sid, stand by. I've got about a minute and change to go here. I want to read you a question that you ask in the book, and then I want you to answer it. Okay. In the end, you write, every biography must also confront the death of its subject. Is the end of cancer conceivable in the future? Is it possible to eradicate this disease from our bodies and our societies forever? What do you think?
Well, I answer the question in the negative in this book. I think that it's unlikely that we will ever eradicate this family of illnesses from our bodies and societies. I hope we can reduce the risk. We can reduce the rates of many forms of cancer by using a combination of environmental interventions, by using and treatments and prevention and screening. And again, it varies from cancer to cancer. But ultimately, as I said before, one of the most chilling things about the fundamental biology of cancer is that the very genes that allow our embryos to grow, our bodies to grow, our brains to grow, if you change those genes, if you mutate those genes, you unleash cancer. I'll give you one quick example. There is a society which has been now quite intensively studied, which is relatively cancer-free. And that society is created by a founder mutation, a change in the gene that makes them cancer resistant. Guess what gene that is? It's a gene that fundamentally controls growth. This is a society of dwarves. in South America. So, in other words, the link between growth, as we understand it, the normal, I'm using that word in the context of statistically normal. I don't mean that if you're shorter in height, you're not normal. You just differ from the statistical. The very drivers of growth that allow us to attain our body size their flip side, in some sense, is cancer.
I want to thank all of you for participating in what has been, I think, a very fascinating hour. Much appreciated to Deborah Davis on the line from the Environmental Health Trust in Pittsburgh, Pennsylvania. Deborah, as always, you're going to hold up your phone there? That's her cell phone, folks. That's her cell phone. She's hooked it up to her BlackBerry. How about that? Okay. Thank you for that, Deborah Davis. Back here in the studio, Alison Symington from the Ontario Genomics Institute, Robert Buckman from PMH, Princess Margaret Hospital, and Siddhartha Mukherjee, author of The Emperor of All Maladies. Thanks so much, everybody.
Thank you. Pleasure.
Thank you.